Hello and welcome to the Print video. I am Sumi Sukanya Datta and today we have with us Dr. Ashok Seth, a renowned cardiologist and chairman of Fortis Scott's Heart Institute. So today we are going to talk about the cardiovascular disease scenario in India and also touch upon the launch of a cholesterol lowering jab Inclisiran which had just hit the market recently. Welcome to the Print, sir.
Thank you.
And thank you for talking to us. And so we'll first start with asking you, what do you think about the rising cardiovascular disease scenario in India, and also that we keep hearing of instances when people are just dropping dead.
You're so right.
Due to sudden cardiac arrests. Yes.
You must understand that India, and for that matter, some of the Southeast Asian countries, are the capital of heart disease in the world.
Right.
50% of the heart attacks occurring across the world happen from this region. We predispose to having coronary artery disease due to unique factors. And the unique factors, as you know, are the common ones: diabetes, hypertension, which practically is in an implosion in our country. Nearly 30% of the patients affected by hypertension. Diabetes is a major scourge in our country. Smoking is on the rise rather than on the increase. Obesity is on the rise. So every risk factor which is there in the West is actually decreasing, while in India it's on the increase. And therefore coronary artery disease is on the increase here. Added to the known risk factors, which is smoking, which is hypertension, which is diabetes, which is obesity, which is work stress. In addition to that, the two most important recent factors, I believe, which have come in are pollution, which is known to cause coronary artery disease, which is known to cause heart attacks because of the carbon monoxide and sulfur dioxide, which actually get into the coronary arteries and cause inflammation and heart attacks.
Yeah.
And of course, the COVID.
Yeah.
And these two got added on more recently over the last few years, should we say.
Yeah.
And therefore, yes, you're right. We are a country predisposed to coronary artery disease 3 times more than West, 6 times more than Chinese, and 20 times more than Japanese.
Oh.
And therefore, we've got to be careful, we've got to be cautious, and we've got to take preventive measures right now. And the reason for right now is because, as you know, coronary artery disease in the young is rising, and majority of it, our population, is the young age group. So we worry what happens to them in 20 years' time or 25 years' time, when natural processes would cause coronary artery disease as well.
Yeah. So COVID, ICMR recently came out with a study which sort of clarified that COVID vaccination at least doesn't have a direct role to play in these sudden cardiac arrests that we are seeing. But do you still think that COVID has, because we are seeing a lot of younger people actually falling prey to cardiac arrests. So COVID itself, do you think, is responsible behind some of these cases?
So I think I have to emphasize that COVID vaccine never caused or rarely caused any reactions.
Right.
And let's put that myth away that COVID vaccine causes heart attacks.
Right.
In fact, the chances of any vaccine causing a serious problem goes down to practically 1 in 100,000 or 2 in 100,000.
Right.
It was 0.0017%. But when you come to COVID causing heart attacks, COVID causing heart disease, I even much earlier wrote this in an editorial of mine in one of the national dailies, which said COVID is not just a lung disease, it's a heart disease.
Yeah.
Primarily because COVID affected hearts. There's an increase in heart attacks 3 times in people who've had COVID than the normal population or the historic population. It's been proven time and again that COVID caused clots in the arteries of the heart, creating heart attacks. COVID caused disturbance on the heart muscle, weakening it and also causing irregular heartbeats, which can lead to sudden death. But let's not forget that not every young person who we see at the moment, it's getting more noticeable because of social media and the fact that it gets picked up, that we see somebody collapse somewhere, and there are visuals of it, unfortunately, on social media. But not every one of those is a COVID-related death. Deaths which are sudden can occur due to multiple factors, especially in young individuals. There are heart muscle disorders which are genetic predisposed and can cause early deaths. There are other forms of arrhythmias which can cause early deaths. In athletes, you've heard that somebody collapsed, a footballer collapsed. Those are congenitally related heart abnormalities, either of heart muscle or heart muscles, or a congenital defect, or for that matter, electrical disturbance of the heart. Yet, in India, we do believe that at least a proportion of those deaths, and I would say it could be 25% of those deaths, could be from unknown coronary artery disease. Not everybody experiences blockages like chest pain and therefore gets warning. Even younger can have a blockage of around 30%, smokers, those who have heavily exercise. Any clotting related abnormalities can create clots on even a 30% blockage, which causes a massive heart attack. And massive heart attack, 10% of those present as sudden cardiac arrest.
Okay.
So therefore, yes, we are seeing more of what is happening, primarily because of social media, but on the other hand, let's not attribute all those young deaths to coronary artery disease, though there will be a proportion of them, which could be 25% to 30%, actually having heart disease which they didn't know and suddenly collapse. So that's why we say people need to understand the risk factors.
Right.
We're not saying that everybody needs to have CT scans, etc., etc. I think that's wrong. I think that spending money for massive, expensive checkups is not necessary. But what we need to know very early on in our life is that we need to understand our risk factors. If you understand that most of the risk factors go unnoticed, hypertension has no symptoms. Diabetes is only picked up when it's checked. Therefore, what do? If you got a family history of a heart problem, somebody in the family having had heart attacks or sudden death at an early stage, we just need to go to a GP, get our blood pressure measured, get our sugar measured, get our cholesterol. The important aspect, we say, get our cholesterol measured and know the risk factors. Make sure that we're not overweight, make sure that we exercise regularly, and we need to look after ourselves.
Yeah.
Actually, it's least expensive to know your risk factors and take care of them at a very early age.
Yeah.
And we don't need hi-fi tests for that. If we control all our risk factors, we decrease the risk of heart attacks by 25% straight away.
Yeah.
More than any drug can do.
Yeah.
And I think that's the most important aspect for our own country. Know your risk factors, take the responsibility of your own health, and therefore know that any of us can be candidates for a heart attack if we're not careful about it.
Yeah. You mentioned some of these tests, sir.
Yeah.
Do you suggest that people of certain genetic predisposition, so family history and all of that, at a certain age should start taking their, these matters more seriously and start going for regular checkups? If yes, what sort of regular checkups?
I think it's a very important point, and yes, absolutely, I would say. If in your own family, either of your parents have had heart attacks at an early age, which means males less than 55 and women less than 60, absolutely heart attack or sudden death, we need checkups right in the beginning by the age of 20. When I say 20, it means blood test for cholesterol, a simple heart echo, an ECG, and blood pressure check, and making sure that we've got no diabetes.
Right.
That's the major test which starts at 20 if you've got a family history of sudden cardiac death or heart attack at an early age. It could happen to our brothers and sisters, and therefore we need our checkups. Otherwise, I would suggest that all males know their sugars, blood pressure, and cholesterol levels by the age of 25 to 30. And all women need to know it also by the age of 30. So that, and these are simple tests. This is just a visit to the general practitioner.
Right.
If we find that we have no risk factors, we should then only have a checkup of those every 5 years. But if we find that we have a risk factor like diabetes, hypertension, then we certainly need yearly checkups. Again, of just making sure that we got all our parameters under control. Risk factors never add up, they multiply. So if we've got diabetes and I get a blood pressure, my risk for developing heart disease goes to 6 times, not to twice.
Yeah.
And if my family history is there, then it goes to 15 times. So for me, what becomes important is keeping all my factors in check and not just one factor. Because I have people coming to me saying, but I did nothing wrong. I've been exercising. I've maintained my habits. And then I say, okay, what else? Do you smoke? Yeah, but I only smoked. But everything else was fine. And then I asked them, what about the family? Yeah, my father had a heart attack. Now look at that. And he's done everything fine. He's running, he's exercising, he goes to the gym, he thinks and he eats nothing. But his risk factor was 10 times anyway, the population, just because he had a family history and he smoked.
Right.
But for him, in his mind, he did everything right.
Right.
So the same thing goes for us to understand that checkups are not exhaustive, but checkups are know your risk factors. Those who have diabetes, those who got a family history, those who are known to have familial raised cholesterol levels, those in whom high blood pressure runs in the family, obesity runs in the family, anybody who has any risk factors starts getting their checkup by the age of 20. If they haven't got it, it's 5 yearly. If they have it, it's yearly.
Yeah. So given that India now has about more than 35% of the people who are hypertensive, do you suggest any sort of population level measures in order to control cardiovascular diseases, instances of strokes?
You're also absolutely correct. Population measures are important.
Right.
Population measures are important in multiple ways. And of course, even our salt intake is hugely high.
Yeah.
Compared to the West. We are actually, compared to the recommended levels, we're actually at 3.5 to 4 times the salt intake.
Right.
And it's been clearly demonstrated that just decreasing salt intake helps to decrease high blood pressure and controls the risk factors of high blood pressure. Yes, we need more education. There's no question. We eat salty food. It's a part of our life. Not just that we eat salty food, we eat the worst adulterated oils that exist because we love to eat outside. And the recooked oils, as you know, it's not the oils which are bad, it's not the fried food which is bad, it is the recooked oil, the type of oils which is bad. And that's where the whole problem comes in. Yes, we can have population measures, but at the end, individual responsibility is a huge aspect of our own.
Right.
And therefore, we've got to define this single fact that prevention of heart disease is in our hands. And in fact, I say it's in our feet. And why do I say it's in our feet? 20 minutes of walking, 150 minutes to 200 minutes in a week, which actually means 40 minutes of walking a day.
Every day, yeah.
40 minutes of walking helps you to lose weight, helps to decrease your blood pressure, helps to decrease sugar, gives you a sense of well-being, lower stress, and can decrease the heart attack rate of your own by 25%. That's more than any tablet which can do it.
Right.
And that's all that's required.
Yeah.
So I think living healthy is a part of our own responsibility. Decreasing heart attack risk is also an equally part of our own responsibility. We better know, I think I've got to tell this messaging very clearly. Each one of us, even me as I sit here, is having a checkup regularly, but could have a heart attack at any time if I didn't have the checkups, even while sitting here, because I see it every day, and I treat every day those people who thought that they were doing fine, but I knew that the moment I saw them, that they had risk factors that they had ignored.
Right.
And only if had they taken care of those risk factors 20 years ago, they wouldn't have had this heart attack or be having any procedures like angioplasties and surgeries at this stage.
Right. You mentioned salt intakes for Indians. Now, 2 days back, this American Heart Association has come up with a review of hypertension guidelines across many countries, and has said that these guidelines should also include the suggestion for introducing low sodium, potassium enriched salt. Can we know a little more about that?
So yeah, there are potassium rich salts.
Right.
But again, I do not encourage that at all at the moment. The reason is getting into a habit of low salt is far more important.
Okay.
Because there are going to be harmful effects of potassium as well. We also know that that's an artificial methodology. We also know that it doesn't take away craving for lesser salt. We also know that some people are going to have kidney disease and develop high potassium levels, which are far more dangerous than high sodium levels.
Okay.
So we don't want to actually advocate that at all. What we want to advocate is namak kam karo.
Okay, salt itself should be reduced.
And the reason for that is, look at the amount of salty stuff that we eat. शाम को समोसा, उसके साथ कचौड़ी खा लेते हैं, चाय के साथ मट्ठी खा लेते हैं, अचार कहाँ गया? अचार तो होना ही चाहिए था. We actually love salt in our country much more than anywhere else in the world.
Yeah.
All our nuts are salty.
That's
Everything
right.
is. Pakode kahan gaye?
That's
So yes,
right.
so we are a salt-loving nation, and we just got to change our habits to lesser salt.
Yeah. So one last question from my side is about this cholesterol lowering jab which has just been introduced by Novartis. Now this is in addition to statins. This is what being said. Could you please help our viewers understand a little more about this drug?
I would.
Yeah, and who is it suggested for?
So firstly, we got to understand that cholesterol lowering is extremely important in our country with this incidence of heart disease that we're talking about. While for secondary prevention, which means those who've already got heart disease, those who've already had heart attacks, those we know who've got blockages, either brain arteries, either heart arteries, either leg arteries, for them it's absolutely 200% indicated to lower LDL cholesterol to those target goals that we recommend, which is less than 70%. And for those who got another risk factor like diabetes, it has to come down to 50. And for those who got 3 risk factors, it's got to come down to 30. If they've got a family history of sudden death, if they had repeated heart attacks, it's got to come down to less than 30 million. We're very clear in that, and that's the targets that we aim for. Though public looks at the normal ranges and say, "Main to bada acha chal raha hu." The second issue becomes, how do we do so? And then there is this primary prevention. Primary prevention for the West is a very obscure situation. But for India, we are very also clear that those with extreme high risk, like a family history, hypercholesterolemia, cholesterols are running high throughout the family has had heart problems, sudden cardiac arrest, hypertension exists, diabetes exists. Even for primary prevention, knowing that they haven't got coronary artery diseases, if the LPA levels are high, if the LDL is high, we would still lower them. But how do we lower them is the real issue. If it's such a large population requiring, we need to lower it with the cheapest available drug, there's no question. And that's why statins, which have been around for a long period of time, which are generic, which is available easily, become the first line treatment in our country.
Right.
We then have alternatives that if we don't achieve those target levels which I'm talking about, which I believe for everything we are doing secondary prevention, which means people who've already had heart attacks or already got blockages, we lower it to less than 50. And if they've got diabetes or if they had repeated heart attacks, we lower it to less than 30. But to achieve those target levels, we may not achieve with a single dose, or they may have side effects from that statin. And the side effects are nothing serious. Somebody complains of muscle aches and pains and say, "Main khai nahi sakta." Then we add another drug. It's a standard protocol, ezetimibe. We actually rely on the cheapest of the medications to get the maximum benefits.
Right.
But there's still going to be individuals who do not respond to those even at the maximum tolerated dose, as we say. Those are the ones which worry us, especially if they are at young age. I've had individuals who we could not lower, and we needed alternative agents to lower their cholesterols further. People who have familial hypercholesterolemia, people who've just run this family history, had heart attacks at a young age, have had heart attacks 2 or 3 times, have had developed blockages over 5 years twice and thrice, have had multiple stents, and they're still not getting their cholesterol down.
Okay.
It is our responsibility to get them cholesterol down to that 30 level that we're talking about. And that's where these drugs come in. So for India, this is not a first line agent, neither a second line agent. This is the last line agent to lower cholesterol. And that's why earlier, as you know, evolocumab came in, which is Repatha is the one which is available in India, but it's evolocumab. And that's jab twice a month. Expensive, but for the person who didn't lower his cholesterol and had heart attack at a young age, it is actually a life-saving drug because it's been known to decrease heart attacks. And we can't run those levels. So for us, it's now become a responsibility as a third-line agent. And we've got now another tablet in between. But talk about it as a fourth-line agent. But that it becomes important. And therefore, when we come to Inclisiran, it's another one of those similar molecules. It changes the genes in a manner of the PCSK9 that it actually therefore lowers cholesterol. It's not a standalone drug. We must remember that every time we add evolocumab as an injection twice a month, is based on what is already on statins.
Right.
It's not replacing one with the other. We go on a first line, we then go to the second line, which is another tablet, we go to a third line, which is an addition of a tablet. And after that, if we haven't been able to achieve those target levels, which can prevent further heart attacks, which can prevent progression of heart disease, we can actually make the patient live longer, then we add the injections. And finally, therefore this injection twice a year is going to have its benefits, while what's been proven for Inclisiran is that it lowers cholesterol effectively on top of statins and ezetimibe and the tablets that we're giving, which are the cheaper. And then you can add Inclisiran twice a year and it still lowers cholesterol.
Yeah.
I think it's a big advancement forward, but financial limitations are always going to be there. But for that individual who we can't get down, I think we owe it to him, if he can afford it, to have an injection twice a month, but not as an alternative to the cheap, effective statins, which is the mainstay of treatment and will always remain the mainstay of treatment, because not just cheap, it's been effective, it decreases heart attacks, it has been shown to improve outcomes, and I think will always remain for our country as the mainstay. Statins and ezetimibe are always going to be the mainstay of treatment.
So in nutshell, it's a very small category of patients who may benefit, but for some at least it will be lifesaver.
And I have patients even on evolocumab who for them is lifesaver. In fact, to the extent I can also tell you that I have patients who come to me and said, why didn't you give me this injection if you knew that I wasn't achieving those target levels? It's for me to decide whether I can pay for it or not. I hope you understand. They had a heart attack once. One tries to get their levels down to normal, maximum doses of tolerated drugs given, it still doesn't come down. And if he has a heart attack 4 years later, well, that's the question.
Yeah.
Now that we have drugs which could do it for him to lower that cholesterol so that he doesn't need to progress to a heart attack. And therefore it becomes a responsibility to inform every patient that there is these drugs available and the target levels are not being achieved. And therefore there is this drug available. It's actually a lifesaver for many patients. And I have a proportion of patients who are actually taking it because they developed episodes of heart attacks, blockages over a period of time and could never lower their cholesterol. And now it's available for them.
Yeah. So with that, we wrap up this conversation. Thank you so much, sir, for being on the show. Thank you so much for watching.